support this vital part of our healthcare system.
My Lords, I thank the noble lady Baroness Mackintosh of Pickering for securing this debate and for overcoming her injury to make it in today. I put this issue of rural healthcare out to Green councillors around England, and what I got back could only be described as a flood of concern. Now, we've heard from the first two speakers in this debate an overview. I'm going to largely narrow down to one particular county, that is Shropshire, which is one of the most rural counties in England, a population of 323,000, around a quarter of which live in Shrewsbury, the rest of which is widely dispersed across small market towns and rural areas. And as the Right Reverend Prelate noted, in the population, 23% are over 65 years of age, compared to the English average of 18.5%. Now, public transport is often simply non-existent. 45,000 people, by the NHS's own figures, live 30 minutes or more from a GP practice by public transport. What's really clear is access has got dramatically worse in recent years. Rural healthcare is often seen as inefficient. It's centralised in Shropshire, either at the Royal Shrewsbury Hospital or Telford's Princess Royal Hospital. And this is undoubtedly cheaper for the NHS, but the cost is transferred to individuals who may well simply not be able to bear that financial cost or may encounter barriers that they simply cannot overcome. Cost, age, disability and the lack of transport lead people seeking healthcare later, which of course greatly increases costs on the NHS in the long run, or simply deciding to go without, with significant social, personal and of course also economic impacts. Many cases, services have just simply disappeared. Cardiology outpatient appointments, including diagnostic tests, used to be available in Shrewsbury, but recently they were centralised to Telford. That's an hour's drive from Ludlow or Bishop's Castle. By public transport, 2 trains and a bus and a hearty wish of good luck is what you need. Another particular area of issue is midwife-led maternity units. There used to be a network of 5 of these. Closure was first mooted in spring 2016, with cost explicitly cited as the issue. There was then a period of short-term closures, often at extremely short notice. So 2 hours later, 2 hours notice, so women were finding on the day they were giving birth that their expected plan for birth just simply could not be followed through. And it's not that there hasn't been reaction to this. There were very strong protests against these closures in Ludlow, in Bridgnorth, in Oswestry. And although the MLUs remain open as a base for antenatal and postnatal care, there's no out-of-hours service. At night, should a patient find themselves with unexpected bleeding or reduced fetal movement, they have very often no chance to get care. And even if you say take a taxi, in many rural areas there simply is no taxi available to take. So that's the reality in Shropshire. And just one more point in that area about community hospitals. We see repeated attacks on the whole concept of community hospitals, and we've seen cutbacks and further cutbacks. But there needs to be a vision for these community hospitals, a strategy of how they can best be used both for the local people and the local healthcare system, taking medium acuity patients to relieve some of the enormous pressure that the acute hospitals are experiencing. And of course, making sure that people are able to visit patients, patients are able to remain in their communities, be part of their communities. And it's suggested that Shropshire could become a centre for training and education for rural healthcare, perhaps teaming up with Keele University to offer better services, meet local needs. Now, just to branch into a couple of other areas very briefly, we're focused on healthcare, but of course health and social care are closely interrelated elements. So I heard from a councillor in North Somerset the huge issue of, in very rural areas, simply finding a carer available to provide care in a small village. And if someone needs that care, if there's one person available, that means that the patient has absolutely no choice at all in terms of the care they receive. If it's not working out very well, there is simply no other option left available. And finally, I want to address, because I think it's terribly important, the issue of shortages of dental care. And I should perhaps here declare my position as Vice President of the Local Government Association, because I refer to recent LGA analysis that shows that rural and deprived communities are particularly suffering from a lack of dental provision. Comparing data from January 2022, the bottom 20 areas, a year on, only one of those had seen improvements. All of the others were going backwards. Meanwhile, the areas with the best access to dental care are actually seeing more and more dentists opening up, offering NHS services. So we're actually seeing a huge displacement of services to where there's relatively little need, and we're not seeing the services coming into these areas where they are needed. And of course, what that means is people either forego dental treatment or resort to DIY dentistry. And of course, that is both hideous in terms of pain,